Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. I have a really interesting case here of a patient who attended with bilateral blocked ears, and this was the worst day out of the two. And upon initial inspection and examination, it just looked like a straightforward earwax occlusion. However, already I can see a thick layer of keratin at the bottom, so dead keratinous skin. And even at this very early stage in my mind, I'm wondering what's lurking behind this wax plug. And it became more apparent the more I tried to remove this wax plug, because there's a lot of resistance and there was a lot of adhesions, especially at the floor of the ear canal. So you've got the wax plug here, and then concurrently and to the side, you've got all this dead skin, squamous tissue, which is the skin that lines the ear canal, the epidermis layer. So the most superficial layer of the epidermis layer of skin is made up of what we call stratified, so layers of squamous. So squamous is flat cells. Keratinizing, so these squamous cells produce keratin, which is a protein also found in our hair and nails. Epithelial, so that relates to the outer layer of skin. So I'm thinking, is this keratosis obturans, or could it be a potential rare external auditory canal cholesteatoma, or is it benign osteonecrosis? And initially I was, because I can't see the whole ear canal at the moment, I was hedging my bets onto a keratosis obturans, but it just didn't have that texture of a keratosis obturans. Sometimes you have to feel that texture when you're inside the ear to have a definitive diagnosis. And I don't want to put any drops at the moment because I'm not sure what's going on, just in case there is exposure of the underlying bone. I just wanted to avoid drops. But you're seeing more and more of this skin now. And it's quite tough to remove. It's very adhesive. Because it's quite deep in the ear, I was reluctant, where possible, to use any other manual instrumentation. Forceps obviously wouldn't do this, because it was this superficial, more lateral part of this plug was quite soft, so it would just kind of stretch it. Obviously, if we had no choice, I would have introduced some manual instruments. I'm not sure if I did or not. I think I managed to remove it just with suction. We shall see. So the patient themselves, their symptoms are obviously a blocked ear. So they had a conductive hearing loss. The sound wasn't able to travel through the ear canal to the eardrum. They also experienced some itchiness of the ear and a very dull pain, nothing untowards. So with the keratosis obturans, normally patients present with quite an acute pain. So again, that's one of the differential symptoms between a keratosis obturans and a canal cholesteatoma. Now, you'll see it in a moment, but it's possible this patient has got very early stages of a canal cholesteatoma. So a cholesteatoma is the formation of a dead skin cyst. It's not shed skin, it's skin that's still lining the ear canal, and it forms into a cyst. Your most common one is your middle ear cholesteatoma, and that's normally secondary. There are other causes. You can have it as a congenital cholesteatoma, so you're born with this epithelial skin in the middle ear, which shouldn't be there. This squamous keratinizing epithelial skin should only be in front of the eardrum, not behind, but sometimes for congenital reasons it can appear behind the eardrum. But it normally happens secondary to a retraction of the eardrum. So the eardrum, especially the top part of the eardrum, the pars flaccida, and the back north region of the eardrum, called the posterior superior quadrant, that they're very common parts of the eardrum, or the more susceptible parts of the eardrum, to be getting sucked inwards, retracted when you've got a blocked eustachian tube and you've got negative pressure in the eardrum. And when that part of the eardrum gets sucked in, it creates a pocket. And the skin that lines the ear canal, the superficial layer, especially the bony part of the ear canal, it all originates from the centre of the eardrum. So the centre of the eardrum is where these skin cells are formed, and then they radially migrate outwards across the eardrum to the canal wall, and then they slowly travel down the canal wall to the entrance. So I managed to remove that plug, and you can see this hyperplasia of a proliferation, so an increased amount of skin that we would expect. So obviously I want to peel all this away. One of the encouraging signs are there's no discharge, there's no otorrhea. And slowly but surely peeling this away, and you can see that skin texture. So this skin it's not desquamated, it's not skin that it's shed off the canal wall, it's still attached to the canal wall, so it is squamous. So squamous, the term squamous in terms of the ear, so the squamous is Latin for a fish scale, I think, so it's a flat skin cell. And in the ear canal, as I mentioned earlier, they're arranged in layers. You get about 10 to 30 layers in the ear. And the term desquamous is when this squamous skin begins to shed. So it's exfoliated skin cells. And desquamous is Latin for descaling a fish. So this skin is definitely squamous skin, it's not desquamous, which is another differential between keratosis obturans and canal another differential is with a keratosis obturans, you normally get a global widening of the ear canal, whereas with the ear canal cholesteatoma, it's more localized. Normally on the inferior canal wall, so the floor of the ear canal, but it can also happen posteriorly to the back section where this part partly is. So you can see the irregularities of the bone. And again, with a keratosis obturans, it's normally quite smooth widening. Of course, it could also be a benign osteonecrosis. So that's another condition where it's the bone itself at the floor of the ear canal, and that's normally inferior only. It lacks the blood supply, so the bone begins to die and wilt away, if you like, and it creates a pothole, it creates a crater, and then the ear canal sinks. To me, it just more looks like a ear canal cholesteatoma. You can see a bit of granulation tissue there. So that the bleeding, it wasn't because we scratched the ear. If it was, it would have obviously been quite painful for the patient, and we would have come out immediately. There was just a bit of granulation tissue, which is inflammatory tissue, that was behind a piece of keratinous skin. And when we removed that keratinous skin, it just ruptured that granulation tissue. So when you have granulation tissue, it's a formation of connective tissue, and it has its own formation of blood capillaries. So when you're removing debris or sometimes the granulation tissue itself, you can suction it, it comes away like flesh. You rupture these new blood capillaries that are formed, so you get a bit of localized bleeding there, so it's kind of more or less stopped already. So you can see this buildup of keratin, and it's in between these irregular surface. So it's like continuous peaks and troughs on the surface of this ear canal, and in between those you've got this buildup of skin. Now it's very difficult to look in there. We had a good shot at the end, so I can't see any exposed underlying bone, but there was inflammation there, so there could be some periosteitis. So periosteitis is a sheath that lines the bone, and it supplies the bone with all the blood, nutrients, oxygen that it requires. And you can see it's a bit red there in that area. And I had a case like this about 18 to 12 months ago, and the case, I'm sure they're watching this video because they do follow me on social media, and it was a very, very similar case actually. And I wasn't sure 100% if it was a canal cholesteatoma, but obviously we referred onwards, and the ENT consultant who they saw, just to be on the safe side, performed a CT scan, and it was then confirmed that they did have a canal cholesteatoma, and they had surgery to remove that, and they then remodeled the ear canal. They put some muscle grafts there to fill in the gaps, fill in these potholes basically. And since, I think the patient's been fine. I think I've seen them once or twice since. They did have another infection, I think, but it was unrelated to the canal cholesteatoma. But I think they're doing well, which is really, really good news. So what I'm doing is just peeling away this squamous skin. Just lifting it away. So when you've got another potential cause for this suspected canal cholesteatoma, is this patient just born with this irregular canal wall, and so this may be a really benign condition. And when you've got this up and down irregular surface of the ear canal, it prevents and slows down the skin from migrating. So the skin, as I said earlier, and I described it, it all originates from the centre of the eardrum, the umber region, and it then radially moves outwards to the edge of the eardrum, and then slowly laterally forwards to the entrance of the ear, and it lines the osseous, the bony inner two-thirds of the ear canal, the skin that originates from the eardrum. But when you've got this irregular surface, the skin is going to be a lot slower in its migration route, and then it has an opportunity to get built up. And when the skin gets built up, it can form into a cyst, and the cyst is lined with the stratum basal layer of the epidermis layer of skin, which is metabolically active. So interestingly, with the epidermis layer of skin, it's got 4 layers in the ear, and other parts it's got 5. But at the deepest layer of the epidermis layer of skin, you've got the stratum basal, which produces keratinoids, and at the most superficial level, you've got the stratum corneum, and that's lined with dead keratinoid skin cells. We call them corneocytes. So it's really interesting. You've got some parts of the epidermis that's metabolically active. It's got a nucleus to cells, and they're alive. Whereas the most top layer, the superficial layer, is actually dead skin. It's metabolically inactive. It hasn't got any nucleus or organelles or intracellular fluid. Instead, it's full of keratin. So with a cholesteatoma, you generally have the 4 layers. You have the stratum basal, and that then you have the layer on top of that, stratum spinosum, then you have the stratum granulosum. I'm just trying to remember all the names. And it forms into a cyst, so it creates a ball, a sac, and the superficial layer of that sac can actually be the stratum basal, and the innermost layer is the stratum corneum, and that stratum corneum in the inner layer of the sac is still shedding the keratinous skin. So that makes the skin sac bigger and bigger, and that's how it can start invading adjacent parts of the ear. So it's a self-developing sac of skin, and the inner layer is dead skin, the stratum corneum layer, and the outer layer is the metabolically active layer of skin. And that outer layer of skin, it releases enzymes, so proteolytic lysosomal enzymes, which start basically chewing up the flesh, and they start chewing up and decaying and digesting the periosteum, which I described earlier. When that's degraded and digested, then the blood underneath, the bone underneath starts to decay because it hasn't got the blood and the oxygen. Of course, these enzymes are still, they begin to take action against the bone itself, and then you can get a bony erosion. The bone expands, and then you'll get a crater created in the ear canal, and you'll have ulceration to skin. And when you've got a crater, the skin that's continuously shedding in the ear, it falls down that crater, and it's a vicious cycle. And in the case of the back of the ear, the canal cholesteatoma can start invading the mastoid bone, which is the bone behind the eardrum. Inferiorly, and to the front, you've got the parotid gland. Anteriorly, so to the right to the front of the ear canal, where the bony part of the ear canal originates, you've got adjacent to that the temporomandibular jaw joint, and obviously superiorly, although a canal term is very rare that it's going to go upwards, but you've got the tegmen tympani, which is the thin sheet of bone which separates the middle ear and the roof of the ear canal to the intracranial cavity, so the skull base basically. So as you can imagine, it can be quite a dangerous pathology. Now, I'm not going to get all this skin out, it's just really, really dry and thick, but this skin is not leading to a canal fleshiotoma, it's more inferiorly. So this is not into a sac. Now, it's good if I can remove it, but obviously we've got to make sure it's not uncomfortable for the patient. The eardrum is otherwise intact. They do have a blockage in the right ear, so if you continue to watch, you'll see the right ear, the appearance of the ear canal is completely different. It's smooth. There was some dead skin on the ear canal itself, which I did peel away. So I'm just mopping up near the entrance. So written to the patient's GP, hopefully they'll get prescribed some antibiotics and some anti-inflammatories just to calm that area down. As a precautionary measure, I have also referred to ENT, and the patient will likely see ENT sooner, given the waiting list. And I've got no doubt, whenever they do see ENT, they're going to get this buildup of keratin in those little nooks and crannies, because there's the really rough surface of the ear canal. So there's going to be a continuous, it's going to be very continuous now for this patient to have the ears cleaned out, because you can just see how irregular it is. And that's just the perfect, in between those raised areas, you've got the perfect region for dead skin now to collect and not migrate. So it's going to be an ongoing problem, I think, for the patient. And hopefully, if it is a canal fleshiotoma, it's very early stages, probably stage 1. So stage 1 is when you get a buildup of epithelial skin, which you saw there, definitely. Stage 2 is the presence of periosteitis, so infection of the periosteum, which potentially there is there, because there was a bit of inflammation. Then you can get ulceration to skin, which exposes the underlying bone, and then the bone begins to erode, so that's a stage 3. And a stage 4 is when the bony erosion starts invading the adjacent structures that I described earlier, so the mastoid bone, temporomandibular jaw joint to the front of the ear canal, the parotid gland inferiorly and anteriorly, and then potentially even, but it's not very likely, but going upwards towards the skull base. Sometimes they can grow medially towards the eardrum. Again, not all, it's very rare that, and it can have some involvement in the facial nerve as well. So hopefully it can be treated non-surgically, whatever it is, but they are going to be definitely told to have their ears cleaned on a regular basis now. Other potential causes, if you poke in your ears and you cause some local inflammation or laceration, you get swelling, and that creates an obstruction for the skin for it to migrate, and then it builds up into a cyst. So it can sometimes just be as simple as that, just poking in the ears. So cleared the plug of wax from the right side. You can see the skin. So there's definitely a migratory problem with the skin, although see, this is the skin here is completely different in appearance to the dead skin in the patient's left ear. So when I mentioned that term, hyperplasia of the dead skin in the left ear, you can see that was a lot more thicker layer of skin. It was really built up, whereas this is a lot thinner. So, and again, with a canal fleshiotoma, it's more common unilaterally, so in one ear as opposed to both. But nonetheless, when I peel away the skin, it can be a bit noisy, so we do got to be careful. Again, I should peel this away. This is a bit thicker, this front section of the skin that's lining the anterior canal wall. The patient has got quite a prominent isthmus. So there's 2 isthmuses in the ear. So the isthmus is a narrowing. The first one is in between the first and second bends of the ear canal. So in the outer half a centimetre to a centimetre region of the ear canal. And then the ear canal widens again, but then half a centimetre away from the eardrum, it narrows Again, once more, predominantly so in the front section of the ear canal, the anterior canal wall. That's the second isthmus, and then it widens, and it widens more anteriorly, so it creates a recess there, and also inferiorly, so to the floor of the ear canal. And if ever you get wax in that region, which in theory you shouldn't, because wax should be secreted on the outer third of the ear canal. Now, of course, wax can trickle downwards on its own accord. Gravity can help do that. So just say you've got wax formation on the right side and you sleep on your left, just the force of gravity can trap that. But normally, if you see debris deep in the ear, I would be more inclined to believe it's either potentially a middle ear cholesteatomas that looks like earwax, or it's actually not earwax, it's just dead skin, squamous skin that hasn't migrated, or eczema or psoriasis, otitis externa, infection or inflammation of the ear canal, which produces proliferation of skin cells, which then obviously would have to die and shed. So things deeper in the ear, I'm more inclined to believe it's dead skin that hasn't migrated off the eardrum, or it has partially, and there's an obstruction as a result. Which essentially what is a keratosis obturans. Keratosis obturans is an epidermal plug. It's a plug of desquamated, so it's skin that has shed off the ear canal wall, but the individual skin cells haven't separated, so you get this lamellar structure. So the skin cells, they're like sheets of, almost like onions, layers and layers of desquamated skin off the canal wall, but the individual skin cells side by side are still interlocked in sheets. So it's extremely narrow isthmus. Actually, it's very hard to see the front section of the eardrum itself. And of course, another common reason, if you see wax very deep in the ear, then you've got to ask whether the patient has been poking inside and pushing it further in, or also if they've been using drops. If you use softening drops, so ceraminolytics, so whether it be, I think in America it's very common to have urea hydrogen peroxide, so carbamide peroxide drops they're called, or dulcilate sulfate, which is almost like, it's also used as a laxative. In the UK, it's more common to use, again, carbamide peroxide drops. So, hydrogen peroxide drops alone are not really used much now. So, in the UK anyway. Sodium bicarbonate drops is common use, but the most common ones in the UK are olive oil based drops. Some people use almond drops, but they don't generally come in a prepared bottle for otic use. So when you say otic use, used for the ear. So if you put these drops in your ears, and then obviously you're having to tilt your head to the side so the drops can penetrate into the wax, it can soften the wax, and then if you don't come back the other way, or even if you do, but it might be too late. So I normally say soak it for 5 minutes and then come back the other way so it drains out. You want to wash the ear out so it comes out. But that could cause the wax to drizzle further down towards the eardrum. Well, that's my time up, guys. Thank you for joining me in that video. I hope you enjoyed it. Take care, keep well, and speak soon. Bye.